So let me ask you just to bring it back a little bit to the endpoints where we started the discussion earlier. When we talk about induction therapy and goals of therapy, how many of us in the panel have a target that they want a patient to be? Let's pick the younger patient population, and if they don't achieve that target, they're going to change therapy before going to stem cell collection. So not PR, but something better than PR, because I think this is a big issue. I see this all the time. People come to me after having received 2 or 3 different induction regimens when I would have been happy with the first and just gone forward and collected cells. Jatin, how do you approach that?
So I think at this time, I mean, it's important because we don't have any randomized data saying to change therapy once you're in a PR, VGPR, to get to a CR, changes outcomes. And the fact that you get into a CR versus a PR maybe speak more to the biology of the disease, and changing therapy is not going to help you, and it's best to move on. A, you're going to expose the patients to more toxicity, limit that stem cell transplant window, limit the ability to collect stem cells. So in fact, I would not propose changing therapies if you have good disease control.
So PR is really what you're happy with.
For me, a PR is sufficient, then move to transplant. I would not change therapies.
I think that's a really important point, and I'll give everybody a chance to comment, because Ravi Vij has presented data on this from the CIBMTR, and it's a retrospective analysis, but I think it supports that kind of an approach. Morie?
Well, I agree. That's the only data we have. Retrospective analysis from a registry that indicates patients who didn't achieve a deep response who went directly to transplant did just as well as those patients who got a second-line, non-cross-resistant regimen to drive the response. Now, there was no difference. The problem with it, it's the best we have, but it predates widespread introduction of novel agent induction. And so in a novel agent era, it's difficult to know, but I must admit, I do exactly what Jatin does. Don't change regimens, move on, go directly to high-dose therapy.
Heather, somebody comes to you from Westchester County, has had a 77% response to induction therapy.
I think I agree with what's been said entirely. The only caveat to that is I do check the bone marrow before I collect cells, and it's the difference between using chemomobilization versus plerixafor NG.
Yeah,
so
absolutely.
I think that in somebody who's had adequate, at least a PR to therapy, I'm happy to move ahead to transplant. But if I do a bone marrow and they have not had adequate marrow cytoreduction, then I'll use chemotherapy mobilization.
We place a lot of emphasis on whether flow shows circulating plasma cells at the time that patients come for consideration. If they have circulating cells, they're getting chemomobilization.
How are you looking for circulating plasma cells, I'm sorry?
Flow.
Microscope. Morie sits down with 15 blood films.
Well, I tell you, coming out from a meeting like this, one of the strong opinions one could develop is that it's even more complicated and more difficult to know what to do. I actually think, to counter some of Jatin's points, you were saying, well, there's no randomized data for this, but there's really no randomized data for 4 cycles, which is just based on historic data from VAD. And one does scratch one's head when you have a patient who still is responding. So you have a patient, for instance, who was getting into a CR, went past the PR, went past the PR, but is still responding to the 3 drugs. And the question is, do I stop or do I keep going? Needless to say, the patient has to be tolerating this well. There couldn't be a situation where one is creating more peripheral neuropathy. But after a long discussion, we decided to keep going beyond 4 cycles. So the patient's completing 8 cycles of induction therapy with the old near CR category now. Is that the right thing to do? I don't know, but certainly I think one could postulate some rational principles why I wanted to do that. And I think a lot of our colleagues are struggling with that concept. I agree 100% with what has been said. But it's just that we need to build that clinical trial data to know exactly what to do now, particularly with a novel agent. So could you do a clinical trial where you do a KRD 4 cycles versus KRD to best response with the endpoint being MRD post-transplant? I think those questions need to be addressed now.
That's fair. Noopur?
Yeah, I don't do anything different. If a patient has achieved PR, I'm very happy to go forward with the transplant. The question which you bring up, Rafael, is a very important question. Does everybody need a transplant? And, we are doing those studies as we speak. The good news is with all of these new drugs now, most of our patients, or 80 or 90% of patients, are certainly achieving better than a PR. So we're in a happy situation where we can begin to ask the question of whether or not a patient should be transplanted transplanted. As of right now, because we don't have the data, at least in the younger patient population, I'm certainly collecting stem cells. The good news is you can collect and store, and we get covered for doing that, which I think is fantastic for the myeloma world. And hopefully when the IFM DFCI data comes out, some of the other data comparing transplant versus just new drugs with the KRD backbone, we'll see where we are with that.
So let's talk a little